So, as you guys know, this is our last lecture before our exam. Today is Tuesday, and it is March 9th of 2021. Our lecture today, we have to finish up our discussion of joints and the movements they allow. In lab, we need to finish up our group presentations on the appendicular skeleton. Now leading up to Thursday, which is our next lab and lecture exam. Same format as everything for that. And then because we have a nice 5-day weekend after that on Tuesday, March 16th, when you guys return, you have your pre-labs. Oops. And again, not reviews. That are going to be due, and they are pre-lab 10, which is pages 254 through 260, and pre-lab 11, which is, and let's hold on, these are due at the beginning of class, pages 290 through 294. Excellent. So that is our game plan, pretty simple and straightforward. So any questions on that or anything else before we get started today? I'm hoping we'll finish out early enough where we can do a Q and a review for the exam to answer any questions you guys have, but we'll see how things go with our group presentations. They went a little long last time, which is awesome because you guys were providing a lot of information, but it does, so we'll see how things go that way. All righty, so any questions on any of that?
We have no quiz today?
No, I could make one up real fast if you would like. But I figured between your 30-point review due and your homework due, it wasn't necessary. But if you guys really want one, I'll make one.
No, I just had a hard time logging in, so I was late.
All right. All right, excellent. Okay, so then since there's no quiz, I think that tends to be the general consensus, although I got a couple private messages of people that wanted them. So I'm just warning you guys that they're out there. No, I'm just kidding. Let's go ahead and get started then. We left off last time and we were working our way through, I'm just kidding, nobody wants a quiz. We were working our way through the structural and functional classifications of our joints. And we also talked about how all of our most of our structural classifications also have specific types, right? So there were, there we go. How many different functional classifications for joints? 3, excellent. Synarthrosis, amphiarthrosis, and diarthrosis. How many structural classifications were there? 4, excellent. Synostosis, which remember is where it's bone connective tissue holding the bones together. Fibrous joints, where it's some kind of fibers or fibrous membrane holding it together. Cartilaginous joints, where it's either hyaline cartilage or fibrocartilage holding them together, and synovial, which we hadn't talked about yet. And remind me again also, how many specific types of fibrous joints are there?
7.
No, for the fibrous.
Oh,
3 for the fibrous, excellent. How many for the cartilaginous?
2.
2, excellent. And does anybody remember, we mentioned it at the end, but again, we haven't talked about it yet. Does anybody remember the specific types of synovial joints? How many there were? 6, there you go, excellent, perfect. So far in the last class, we talked about everything except for these. And so that is what we need to do now. Now that we've talked about and identified all of these, and there is one more thing we know about all 6 of these specific types of synovial joints, because we know our functional classifications and our structural classifications relate to each other. What is the one thing we know about all 6 specific types of synovial joints? They're all diarthritic, and all diarthritic joints are synovial joints. Excellent. So that is the one thing that we had talked about so far, but let's get more in depth. Synovial joints, with there being 6 specific types, not surprisingly, are the most diverse in their shape and structure, right? They go from the largest, which is probably your hip joint, to, remember those 3 small tiny bones we learned about inside of our temporal bone, those auditory ossicles? Those tiny little bones, which all 3 together fit on a penny with still plenty of room on top of it, all form synovial joints with each other as well. So they can be quite diverse in their structure. However, there are some basic components that are necessary for all synovial joints. And in particular, there are 4 characteristics. Oops, come back here. There are 4 characteristics that all synovial joints must have. And so when we look at this very generic example of a synovial joint, we can see those 4 components. And I'll go ahead and write it first, and then we'll go through all of it as well. For starters, there's this bluish material at the end of the bones where the joint is formed. Any idea what that bluish material might be?
Articular cartilage.
Absolutely, it is articular cartilage. Articular, of course, means associated with the joint, and so this is indeed cartilage that is associated with the joint. And of course, what tissue type do we know this articular cartilage to be?
Hyaline.
Hyaline cartilage. And what did we say the function of this hyaline cartilage was?
Doesn't it kind of add like a barrier for friction in the joint?
Absolutely. It cushions the bone so the 2 pieces of bone aren't banging against each other. It provides a smooth surface so that the joint can move in a reduced friction environment. So it reduces the friction, reduces the wear and tear, protects the ends of the bone. Absolutely. And notice those are completely contained within a joint cavity. So the synovial joints are the only joints that have a joint cavity. Right? This is a space that surrounds the articulating surfaces, let's say it that way. Now, this joint cavity is formed by what we call the joint membrane. I don't want to say this. That forms it around. This joint membrane has 2 layers to it. The first of these layers is the outer layer, as we can see here in this illustration, is what we call the fibrous capsule. And in fact, we could call it a joint capsule if we want. Let's do that. I like that better. We have this fibrous capsule that is made up of a dense irregular connective tissue, and it provides structure. And helps to maintain the integrity of the joint. And so again, notice you can see that here. Let's use a different color this time. this big whitish outer structure on the outer surface of it. Notice I'm not talking about this ligament that is connecting over the top. I'm talking about this outer layer here that is white on the illustration, right? So if we cheat and go back, we can see it there, that white layer there. Notice I make a point of emphasizing that because inside of it in green is a thin, narrow green layer that lines the inner surface of this joint cavity, this joint capsule. And the inner layer is your friend and mine, the synovial membrane. Remember, synovial membranes are one of those things that we talked about back in the last section. We know, like all membranes, it is made up of an epithelial tissue sitting on top of a connective tissue. And remember, both the epithelial tissue and connective tissues of our synovial membranes were special. Remember, it doesn't have a true epithelial tissue. It has clusters of epithelial cells. Remember what we called a scant layer, where we have this individual clusters of epithelial cells along the surface. And our connective tissue was, of course, a real connective tissue, because of course that's the answer to everything. But remember, it also said it has an extensive matrix. It has more fibers in it, and those thicker fibers give it more structure, more integrity. And we learned one more thing about that synovial membrane. What, of course, is it that our synovial membrane does?
Secretes synovial fluid.
Absolutely, and that is the fourth thing that is necessary for a synovial joint. The synovial fluid. Of course, the synovial fluid is made from the membrane, and it fills the joint cavity. And if you remember when we talked about it in the past, what did we say that this synovial fluid does? Anyone remember? Makes it delicious. There you go. Reduces friction. I like that. It provides cushioning. But notice, we could have filled this joint cavity with adipose tissue, and it would have done the exact same thing. So is that what our synovial fluid is? Do you have the exact same synovial fluid in your synovial joints that you had when you were a baby?
No.
No. With our synovial fluid, it is constantly being produced and reabsorbed. So it is constantly being circulated. We can cheat a little bit here. It is making it and then reabsorbing it, making it and reabsorbing it. It is constantly being cycled. So that must mean it's doing something else. And if you remember, the something else it is doing is it is bathing across the surfaces of the hyaline cartilage. Remember, hyaline cartilage is avascular. So by having this synovial fluid constantly being produced, it is able to provide oxygen and nutrients to the cartilage. It is able to absorb and remove wastes. So its other major function is to maintain the articular cartilage. And so you can see how these four components, the articular cartilage, the joint cavity, the joint capsule, and the synovial membrane, subsynovial fluid, all work together to maintain the integrity of this joint and allow it to be that free moving joint that we have talked about. Now I've made a bit of a mess of the screen here, but I've got the pretty pictures that do the same thing. We have our articular cartilage, we have our articular or joint capsule that has that fibrous capsule and synovial membrane. We have our joint cavity, the space that is formed by it, that contains our synovial fluid. And again, I want to emphasize that every single synovial joint in your body has these four components. whether it is those tiny little ones between the malleus and the incus in your ear, or whether it is between the head of your femur and the acetabulum of the os coxa. All of those synovial joints have these 4 components. These are the 4 things that all synovial joints must have. All right? Questions on that? Stunned silence. Excellent. What I love, first thing in the morning, 2 days before the exam. Spectacular. Now, if I'm saying that
how much of it do we need to memorize? Please
how
don't
about
say all
of it? Yeah.
No.
Could not a essay question be identify and describe the major components that are necessary for a synovial joint? Yeah, that makes a spectacular essay question. And we get to add to it. Because while these are the 4 things that all synovial joints must have, and I keep emphasizing these are things that they must have, then that means that there can be things that are there that aren't necessary, but some joints may have. There are indeed, well, good. The skeletal review should be rough. You want it to be rough because you want it to be hard, because you want to learn that information, because you're going to be responsible for it in 2 days. Remember, this afternoon, the key for that will post, and I strongly encourage you to look at it to make sure you see what you got right and what you got wrong. Because any assignment that was worth 30 points, is it likely to end up on the lab exam and the lecture exam? Yeah, almost certainly. Absolutely. Well, you better figure it out by 2 days, because it's going to be on the exam. I guarantee it. All right. Accessory structures are not things that a synovial joint must have, but let's say it this way. Most synovial joints have 1 or more of these accessory structures. Just remind your husband that these are short-term sacrifices for long-term gains. Also remind him of the fat paycheck you'll make as a nurse, and so that'll keep him around. All righty. Most synovial joints have 1 or more of these following structures. So again, they're not required for synovial joints, but many of them have them. The first is simple. There are often accessory ligaments and tendons that help to support them. In fact, we can cheat and go back to that previous picture. Notice here on this previous picture, you can actually see where they actually have a ligament that is helping to support this particular joint. And how do I know that's a ligament? What's the definition of a ligament again?
Muscle to muscle.
Ligaments go muscle to muscle or go bone to bone. There you go. Oops. Whereas a tendon attaches what?
Muscle to
Muscle
bone.
to bone.
Excellent. And notice that's what we see an example of here. Notice we happen to have a muscle. This particular muscle happens to be the long head of the bicep brachia. And notice its tendon goes up over the head of the humerus and actually attaches to this roughened up area above the glenoid cavity on our scapula. Does anybody remember what this bone feature is? Because it's going to be on the exam. What was this roughened up area above the glenoid cavity on the scapula called again?
Acromion? Was it the acromion or coracoid?
No, acromion is up here. Coracoid is up there. No, this was right above, literally right above the glenoid cavity. Anyone remember?
Superior or something.
Close. It is supra above the glenoid cavity. It was the supraglenoid tubercle.
Or tubercle.
Tubercle, right? Because it's a muscle attachment point, right? Definitely one of the bone features you were responsible for on the exam. Tubercle, not fossa. The fossa is the indentation. The point being, notice this tendon of the bicep brachia attaches to a bone feature we're responsible for. But notice by traveling over the head of the humerus, it is helping to stabilize the head of the humerus into the glenoid cavity, helping to support your shoulder joint. All right, so we have these accessory ligaments and tendons that can help to assist in stabilizing a joint. We can also have these structures called bursa, or what are also known as bursa sacs. A bursa is basically an extension of the joint capsule. So again, if we go back to a really simple illustration, here's bone 1, here's bone 2, and as we know, there is a joint cavity that is formed by the articular capsule that surrounds it. So articular capsule comes off this way. What can happen is a portion of that articular capsule can actually extend beyond the joint, forming this fluid-filled pillow. Now remember, this articular capsule, again, is lined with the fibrous tissue on the outside and our synovial membrane on the inside. And since it's lined by the synovial membrane on the inside, it also will be filled with synovial fluid, just like the joint cavity itself will be. So basically, what these bursa produce is a fluid-filled pillow, essentially, helping to stabilize and cushion the joint. Notice again here in the shoulder joint, there is one of these bursas between the acromion of the scapula and the head and neck of the humerus. Because if you think about it, as you are raising your arm laterally, and we'll identify what kind of movement that is in a minute, and we continue to go up, you don't want to necessarily be banging the neck of your humerus on the acromion of the scapula. So by having that bursa there, that fluid-filled sac, it can provide that protection. Of course, when irritated, the same way that the joint cavity can get an increase in fluid and it can expand from that increase in fluid, our bursa can increase in fluid as well and swell with fluid as well. And when that occurs, what do we call that condition?
Bursitis.
Bursitis, absolutely. So bursitis is an inflammation of that synovial membrane inside the bursa, causing it to swell. Notice in this case, it can actually put pressure on the humerus, lowering it in the joint cavity and limiting your range of motion. Did I answer your question, Yulia, or did you, I was trying to finish what I was saying.
It was, I'm sorry, yeah, it was a little backtracking. I was having a hard time differentiating if something is a tubercle or like there's different names for similar appearing indentations or like bulging things on bones. Yeah. And I was wondering if you could briefly go over them and remind us.
So what I would encourage you is you have a table in your textbook that talks about the differences between like a tuberosity and a tubercle. Both of them are like, for instance, typically roughened attachment points for muscle, whereas a tubercle tends to be smaller, a tuberosity tends to be larger, right? Trochanter is a bigger one. So again, you have a whole list in your textbook of what that vocabulary means. So I would encourage you to look at that vocabulary list there to help you to identify it. And again, as we've learned, most of the time they use the right terms in the right places, but sometimes they can throw us curveballs as well. But yes, there are general definitions for these, but rather than sitting here and listing them off, I think the best thing to do would be to look at that list in your textbook. Okay, because that will help you to remember these things as you're learning them for the exam. All right, so we talked about the bursa and we talked about bursitis. One of the interesting things that can happen with these bursas is they can elongate and actually wrap around tendons. We see an example of this here, again, with that tendon of the bicep brachia. This tendon of the bicep brachia is actually unique because it actually, not unique, but is interesting in that it actually goes into and enters the joint cavity, whereas most are on the outside. But notice there is this elonged tube that is formed of the bursa that wraps around it. And that's basically what a tendon sheath is. And we have one here in the shoulder, but as we talked about already in this class, the one that most people are familiar with is the tendon sheath that is located here over the carpals. Remember, we learned how the carpal bones form this indentation that we call the carpal tunnel. And within that carpal tunnel is this tendon sheath that wraps around all of the tendons that go through it to the hand. The problem is if you do a lot of repetitive activities with your wrist, those tendons swell and they get restricted within that tendon sheath. That causes congestion of the tendons, which can cause pain. It can also restrict blood vessels, stopping blood flow to the fingers. It can cause constrict nerves, so you get a weakness or a tingling sensation or numbing in that area. And as we talked about last time, what do we call that condition?
Carpal tunnel.
Carpal tunnel syndrome. There you go. Absolutely. Carpal tunnel syndrome. All right. In extreme cases, right, one of the ways they can actually resolve that is actually going and cutting that tendon sheath. By cutting that tendon sheath, they can loosen that space and they can improve it. Now, it's a pretty extreme solution for that type of a problem because there are going to be complications with cutting that tendon sheath. But in some cases, when people have chronic carpal tunnel that can't be resolved in other ways, they will sometimes resolve it surgically. Yes, Yulia, do you have another question?
Yeah, I was curious if when we have like inflamed joints, is it too much fluid or not enough fluid? And does it have anything to do with the fluid or no?
When we have what kind of joints?
So inflamed.
Yes.
And then my second question would be if it's inflamed, is it going to be looser or tighter?
Great question.
Like articulation.
So let's actually, that's actually a great question. Let's actually go back to the previous question. I mean, the previous picture. So you absolutely have the right idea. When there is some type of irritation to the joint, typically that irritation influences the synovial membrane. And so what happens as a result of it is it increases production of synovial fluid. Normally, we are making fluid and absorbing it at the same rate, maintaining homeostasis. Well, now we've irritated that joint cavity with that synovial membrane, and so there's an increase in fluid production, and you get a swelling of fluid in that joint, which typically tightens and restricts the movement of that. Now, this is caused by an irritation of the membrane. So of course, the best thing to do is to reduce movement of it and to rest it, right? And do things along those lines of cold can decrease synovial fluid production. So you ice it to help to bring down the swelling, right? All of those types of things are the best thing to do. Of course, if you're that quarterback who has to go out in the second half and throw 3 touchdowns, you don't have time to rest it. So what do they do in those situations? If you're that quarterback at halftime with that swollen elbow joint, what do?
Oh, they stick a needle or something?
Yeah, exactly. They stick a needle into it and suck out all that excess fluid. When they do that, they get that mobility back. Taping it would restrict the mobility. We don't want to, but that's what they should do, but that won't help them if they need to throw those touchdown passes. So they stick a big gauge needle in there and suck out the excess fluid so that the inflammation goes down and they're able to use it. Of course, 3 hours later, not only are they still going to be irritated, they're still going to be producing synovial fluid, but by sticking a needle through the membrane, they've irritated it even more. So they're going to be even more swollen and in more pain 3 hours later. But 3 hours later, the game will be over and they've won and they've made their money. And they've, more importantly, helped you win your fantasy football league. And that's all that really matters. All right. Things we do for sports. So yes, so when it is, yeah, so I mean, again, obviously there's the right things to do and then there's the things that people do. All right, excellent. All right, so did that answer your question, Yulia? Silence, I'm going to take as a yes. All right, excellent.
Yes, it did.
Okay.
Sorry, I was getting my son a snack.
Excellent. Arrow, great question. So when you crack your knuckles, no, it does not make the joints swell. So absolutely, it is not bad for your joints. They're basically when you crack your knuckle. So when you crack your knuckle and then you can't crack it again immediately, that is the most common type of cracking that we talk about of knuckles. What you are actually doing is taking advantage of the most important force in the universe. And of course, what is the most important force in the universe? What makes the world go round? Pressure. There you go. Absolutely, pressure. So let's say this is your joint cavity. When you push on that joint, basically what you're doing is you're expanding that joint cavity. And of course, as we know, when the volume of your joint cavity goes up, that causes the pressure inside there to go down. When the pressure decreases, it basically causes gases to come out of solution. That decrease in pressure causes gases to come out of solution. And those gases coming out of solution is that cracking noise that you hear when you crack your joints. No, just the knee. There are no tiny patellas between your digits of your fingers. Yeah, there you go. Say because and in fact, not only is it not bad for you, again, and that's why you can't crack it again immediately because you've already pulled the gases out of solution. We have to accumulate more gases in there before it'll work. Right? They actually have done studies on this, and not only are there no long-term implications of cracking your joints, it doesn't affect or weaken or damage the joints or the joint cavities or the ligaments or tendons or anything along that, but they actually did a study a couple of years ago that showed that people's manual dexterity actually increased if they cracked their knuckles before doing their activity than they did afterwards. Now, there are some people that have like a joint, like a wrist or something, where they can kind of get that cracking noise continuously when you do something like that. That is typically caused by a displacement of a ligament or a tendon. That ligament tendon gets displaced and snaps back, and that's snapping back, and that's why it can be done repetitively. So that's the things that can do something like that repetitively. It's typically a tendon or ligament that is being displaced and snapping back into place. Again, so here's the problem with the vertebrae, and I know there's it's a huge TikTok thing right now where people are doing this thing where they're cracking their vertebrae. The concern with the cracking of the vertebrae is that while you're cracking the joints of your knuckles or your wrist or your knees or something along those lines, there aren't a lot of components in there that can be seriously damaged. The problem with the vertebrae is the vertebrae's primary job, as we've talked about, is protect the spinal cord. And displacing or stretching the vertebrae out too much does run the risk of damaging either the vertebrae or nerves that are passing through there, right? So it is not something that is recommended and should be done regularly, absolutely, because of that, because of the added risk. The cracking of the vertebrae themselves isn't inherently dangerous, but it's the potential damage to the spinal cord and to the nerves that could cause the problems with that. And don't even get me started on chiropractors. Chiropractors are almost as bad as chemists. They're not real doctors. It's a total whack job thing. They can do as much harm as good. They're not real doctors. Don't listen to chiropractors. All right. Yes, real doctors who tell you to get a vaccine, those are the doctors to go. Chiropractors are not real doctors. And parents who are doctors don't count if they told you not to crack your knuckles because they just didn't want you to crack your knuckles. All right. PT is fine. All right, let's talk about some more accessory structures of the joints. The next one are chunks of fibrocartilage that can be found inside of some of our weight-bearing joints. The most common example of this is in the knee. In the knee, we have these two big, large disc-like structures that sit between the femur and the tibia, made up of fibrocartilage. And this fibrocartilage within this joint acts as an additional cushion and provides additional structure to maintain the integrity and shape of the knee joint as it is being used in this big, heavy, weight-bearing location. Again, this single is meniscus, the plural are menisci, but that's again, articular discs. And again, the key here is these are fibrocartilage. Notice all joints always have, all synovial joints always have that hyaline cartilage that we were talking about. That's not what we're talking about. This is additional cartilage, a fibrocartilage that is located in this joint, providing extra protection. All right. There can be chunks of adipose, like fat pads. Again, you have a nice fat pad inferior to your patella, helping to provide some cushion and protection that you can see there as well. So like I said, most joints have one or more of these accessory structures, right? But again, it's not required. There are only the 4 that are required to be a synovial joint. Now, notice also there are a lot of very elaborate joints. Some of the most elaborate ones are probably our jaw, between the mandible and the temporal bone, our hip, our shoulder. But for this exam, there's only one specialized joint I'm going to hold you responsible for, and that is the knee. Like all the joints of your appendages, you need to know the bones and bone features that form them. But you're also going to be responsible for some of the accessory structures that are found in here, providing this additional protection and support for this joint. So there's some great pictures on in your modules that show the knee, show the knee joint and the components that you're responsible for. I don't want to talk about the yet because we haven't talked about the femur and the tibia yet. We need to talk about what bones and bone features make it. And then once we do that, we'll talk about the accessory structures. So after the group presentations, the last thing we'll do today is go over the knee joint together to make sure we understand what you are responsible for there. All right, questions on that? All right, with that, we are done with all of the basic components of a synovial joint. However, we now need to talk about, identify the 6 specific types of synovial joints. For each one, we need to know the shape of the articulating surfaces. We need to know the type of movement they allow. Right. We know they are all going to be diarthritic, allow free range of motion, but we have to talk about the type of movement that they allow. I guess it helps if I spell movement right. And we need to know at least 1 or 2 examples, or 2 examples of each of these types as well. So let's do that. Now, before we can talk about these 6 types, we have to go back to this idea of the type of movement that they allow. Usually, I've got my big yardstick and I've got my desk in the classroom that I'm able to use to show this, but we can cheat. Need something. Here we go. Got a box and a pen. And when we talk about this box and this pen, and we talk about the relationship of them, we can talk about the types of movements that are allowed in a synovial joint. So these are the 2 bones. This is bone 1, and this is bone 2. Now, the first type of movement that can occur between these 2 bones is what we call a gliding or a non-axial motion. Notice with this gliding or non-axial motion, the pen moves freely across the table, but the angle between them doesn't change. They always stay at a 90-degree angle. This one I think is actually easier to show with your hands. You just take your hands and push them together. And as you put your hands together, you can basically glide these across the surface of each other, up and down and left and right and all around, but the angle between them never changes, right? They're always still in direct contact. So this is what we call a non-axial, axial having to do with the degrees or the angle. So there's no angular movement with this one. And instead we get this, like I said, this gliding type of motion, with this non-axial gliding type of motion. Now, the second type, of course, would then be angular. With an angular movement, the tip of the pen stays in the same direction, but what happens is we can decrease the angle between the two of them or increase the angle of the two of them, right? So this is, of course, going to be an angular type of motion. Now, when we talk about angular types of motions, we can have angular types of motions that are just in one plane. And remember, one of the examples we use for this is the joint between the phalanges. I can change the angle between these two bones, but only on one plane. So this is a uniaxial motion. However, the joint between my proximal phalanx and my metacarpal 2, so metacarpal 2, proximal phalanx 2. Notice this one I can go forward and back, but I can also go left and right. So notice there are two axes that I can move this one on. So what type of axial motion would this be?
Biaxial.
Biaxial, absolutely. And here in my shoulder, again, the joint between the head of my humerus and the glenoid cavity of my scapula, I can go up and down, I can do left and right, and I can do all sorts of places in between. When I do that, that is what we call multi-axial. So notice with our axial motions, they can be uniaxial, which would be one plane, one axis that they can move. Biaxial, which would of course be two planes, and multi-axial, which would be three or more planes that they are able to move along. Now, when you have at least biaxial, and actually I'll use my finger because it's easier to see. When you have at least biaxial motion, where you can go up and down and left and right, you can actually do this sequentially, where I could start up and then go right and down and left and up. And notice as I do that, right, what happens is the tip of my finger is basically making a circle. It's easier to see this with a multi-axial. Notice with this, my shoulder stays in the same location, but my hand makes this circular type of motion. That type of motion is what we call circumduction. So a circumduction is when you get this circular motion from going two axes or more, and you put them together in a circle. Notice this is different from our last type of motion. Our last type of motion is a rotation. A rotation is when it moves along the longitudinal axis. So notice the angle is not changing between the two, but I can rotate the pen. I know my pen's kind of wobbling back and forth, but you get this rotation of it. No, my finger, so notice here I can produce circumduction, but because this is a biaxial joint, it's basically going from here to here to here to here, and it's a little wobbly because it's not as smooth as a motion because it's just a biaxial joint. Your shoulder joint, which is multi-axial, allows for much more fluid, much smoother motion. But yes, as long as you have biaxial motion, you can do circumduction. So I am able to do circumduction. It's just not as smooth, it doesn't feel as smooth as when you do it with your shoulder because your shoulder is multi-axial. All right. And so again, that rotation is along the longitudinal axis. All right. And so we have that rotation. So those are the types of motions. We have angular motions, non-angular motions, and we have rotations. Notice that rotation, and I have to use the pen for this. This is a uniaxial rotation, and it's rotating along one axis. Notice if I were to turn it this way, this would be a rotation as well, right? But this would be a different type of rotation. So this along the axis is just a uniaxial rotation along that longitudinal axis of the bone. So these are the types of motions that our joints can allow. So when we identify our 6 specific types of synovial joints, we have to say which of these types of motions they allow. All right, let's take a look at them. And again, understand the articulating surfaces. The shape of the articulating surfaces is what determines the type of motions they allow. The easiest example of this is a planar. With a planar type of joint, we have 2 flat surfaces that are against each other. And again, they provide that gliding non-axial motion. The place we see this the best is in our short bones. Notice our short bones are these kind of block-shaped bones. And again, you got to be careful. When we talk about the wrist, and I see my wrist, notice I got this biaxial motion. But what we commonly think of as the wrist, now we know because we just finished talking about it in the last class, is basically made up of 4 bones. It is made up of the styloid process of the radius. It is made up of the styloid process of the ulna. And then it is made up of the scaphoid and the lunate. So notice here, oh, here, I can use this even better. Here is the scaphoid. Here is the lunate. And basically what happens is the head of the radius and its styloid process stick up here. The head of the ulna, I mean, not the head of the ulna and its styloid process head here. And so we have these bones, and these 4 bones form this ellipsoidal joint between the wrist and the hand. This is what we actually commonly refer to the wrist. So when people talk about the carpals being the wrist bones, it's not entirely true. They form the base of the hand. So if you want to see their planar motion, what you have to do is actually stabilize your wrist. And when you stabilize your wrist, notice you can still kind of waggle your hand back and forth. That ability to waggle your hand back and forth is because those little flat planar joints between the carpals are gliding against each other. So I'm not moving the wrist. The wrist isn't what we're talking about. We're talking about the joints between the carpals. You can do the same thing with your foot. You have that ability to evert and invert a foot, turn your foot inward, turn your foot outward. That ability to turn your foot inward and outward is because of the sliding of the flat bones of the tarsals, which we haven't talked about yet, but we will talk about today. So these joints between our flat bones are perfect examples of these planar joints that provide that non-axial gliding motion. All right, questions on that? All right, excellent. Stunned silence. Let's move on. Probably one of the most common types of synovial joints is the hinge joint. As the illustration shows, basically what you have is you have a convex structure. Convex is something that curves outward that sits in a concave structure, something that curves inward. So you have a concave surface and you have a convex surface, and those 2 sit together. Again, notice here's one of the most classic examples. The convex trochlea of the humerus sits in the concave trochlear notch of the ulna. So you have a circular convex into an indented concave, and this allows one-way uniaxial motion. We can change the angle using that uniaxial motion. And there's lots of examples. Your elbow, your knee, your ankle, in between the phalanges. Remember, not the phalange and the metacarpal, but in between the phalanges. All of those are examples of hinge joints that allow one-way movement. All right. Questions on that? Remember, when you guys don't ask questions, I just assume you've all mastered this stuff and we move faster to get through it all. So excellent. All right. 3. A condyloid or ellipsoidal. Well, again, hopefully you're not soaking it in too much. Hopefully this is stuff you guys have looked at already this weekend. You knew we were going to be doing this. You knew the test was in 2 days. So this hopefully isn't the first time you're seeing this stuff. If it is, shame on you. A condyloidal or ellipsoidal is similar to the hinge in that we have a concave and convex surface. However, in this case, the convex surface and the concave surfaces are elongated. So the real key to these is we have elongated surfaces. And these elongated surfaces allow us to be able to make biaxial motion. Again, notice the example they are giving us here between our metacarpal and our proximal phalanx. There we have an elongated condyle, which allows us to have biaxial motion. Basically, between the scaphoid and the lunate and the radius and the ulna, we have that biaxial motion. So that's another example of a condyloid or ellipsoidal type of joint. All right. So lots of examples of these. The classic ones between D2 and D5, between the metacarpals and the proximal phalanges. However, notice we didn't say finger 1, because as our group that presented that pointed out to us, there is a very special type of joint found in the thumb of our hand. Notice it is located right here between the proximal the first metacarpal and the trapezium. Right. I'm not going to bother drawing this, but you can see in the illustration basically what they've done. Actually, I lied. I am going to draw it. They have taken that elongated convex and that elongated concave surface and basically folded them over on themselves. So we have this elongated folded convex and this elongated folded concave. Again, my artistic skills are horrible, but you see that what it produces is this very special joint found in one location and one location only in the body. And that is here in our thumb. And this joint in our thumb is truly powerful. It is what has allowed us to be the masters of the universe. All right, this saddle joint, right? Because what we used to think is obviously the smarter you were, the more likely you were to be in charge. Do we have the biggest brains on the planet?
Not really.
No. Blue whales, elephants, they have the biggest brains on the planet, right? However, that's cheating. They're way, way bigger. So then they said, okay, well, we can't use that because that's not fair anymore. So let's go by relative brain size, the relative size of your brain to the relative size of your body. Because while a whale has the largest brain, it also has the largest body. And so compared to the size of its body, its brain is actually tiny. So when we come to comparing relative size of the brain, where do we end up on the scales there?
Probably a bit higher.
A lot higher, right? Are we the largest? Are we 1? Did we get the gold medal?
I wish.
No.
Nope. We get silver. There is one organism on the planet that has a bigger relative size of their brain to their body. Anyone know what it is?
Is it dolphins?
Dolphins, absolutely.
I just saw a dolphin brain for the first time this weekend. It went viral on Twitter, so.
Oh, cool. Well, they're huge. Dolphin brains are huge. And if you think about it, the planet is 75% water. So why aren't dolphins ruling everything and we are?
So you have thumbs.
Exactly. The opposable thumb, right? If we learned anything 5 years ago, it is that all you need to do to rule the universe is to be able to tweet. If you can tweet, you can rule the universe. That ability of having an opposable thumb allows us to hold tools, allows us to grasp, climb, and most importantly, it allows us to tweet. So having that opposable thumb is vitally, vitally important, right? The dolphins don't have an opposable thumb, and so that is why we rule the universe and they do not. All right? And we've known this from ancient times. And by ancient times, I mean way back when I was in high school. Because back when I was in high school, if you were suspected of drunk driving, the police would pull you over. And one of the things that you had to do as part of the sobriety test was go A, B, C, D, D, C, B, A, A, B, C, D, D, C, B, A, A, B, C, D, D, C, B, A. And so you'd sit at the bar drinking, practicing that to make sure you could wait home. A, B, C, D, D, C, B, A, A, B, C, D, D, C, B, A, A, B, C, D, D, C, B, A, which as you can see, I can still do even with all the vodka I've had before breakfast. All right, excellent. Questions on that? Only place we find it, but that opposable thumb is, I've had lots of practice. Opposable thumb has that again, that key to being able to do that. Excellent. All right. This next type of joint is kind of a fun one. It is a pivot joint. A pivot joint, as the name would indicate, if you look down at it from the top, is kind of a peg and socket type of joint, where you basically have a bone that has a socket in it, and then you are going to have a second bone that has a nice circular peg shape that is going to sit in the middle of it and allow it to be able to move. Now, if I think about it, have I seen any bones that we've learned about so far that have big round holes in them that our other bones sit in? No. So it's a little bit of a cheat, but if you notice here on the illustration, we see how that cheat works. Notice here, we indeed have that nice big round head of the radius. And we also see how the lateral edge of the radius sits in the radial notch of the ulna. So we have our ulna with its radial notch. We have the head of the radius. But then notice there is a ligament. And that ligament basically wraps around the head and stabilizes it in place. And that is what allows the head of the radius to rotate, basically that non-angular or uniangular, whichever you want to call it, that rotation. And again, really the key is this is a rotation. Come on, I want that. There we go. Along the longitudinal axis. There was one other place where we saw a bone that had a notch and we saw a circular bone that sat in it and allowed for a rotation to take place. Does anybody remember that other location where we saw that rotation that was able to take place? Yep. Close. It's not so much where the spine enters the skull, but you're really close, Amanda. What were the bones that were involved there?
Atlas and axis.
Atlas and axis, absolutely. Remember our atlas and axis, that axis has the dens that sticks up. And then it goes against the anterior tubercle, basically, of the atlas. A tendon holds it in place, and that is what allows us to rotate our head. So that ability to rotate our head between the atlas and the axis is another great example of where we have one of these pivot joints. So notice only 2 or 3 locations of the pivot joint, really only 1 location of the saddle joint. And our last joint, no, tibulofibular is a tibulofibular joint is a different joint than that. Well, we'll talk about that one a little bit later. The last one is one we only have 2 of, and these are the ball and socket joints. What are the 2 locations where we have a ball and socket joint?
The femur and the shoulder.
Yeah, absolutely. The hip and the shoulder. Let's do it that way, right? Absolutely. The hip and the shoulder. Here's the one we've talked about already. Notice you have a nice big ball-shaped structure that is the head of the humerus. and it sits in this nice open socket that is the glenoid cavity of the scapula. The other one is in the hip. These, and again, between the femur and the os coxum, again, we've got groups that are presenting that today. Notice with this type of joint, you have the most flexibility of movement. We have multi-axial motion. So again, it can go left and right, it can go up and down, it can go in between. But notice also, if I cheat and move this to the other side, it also allows for rotation. So notice, I'm going to cheat, bend your elbow. When you bend your elbow, then what you're able to do with your elbow against your side, you can bring your hand towards the front and bring it back. Now notice when I drop below the screen and you can't see my forearm anymore and you just watch my shoulder, my humerus, you can see that I'm able to actually rotate the humerus. I can rotate that humerus left and right, inward and outward, and we'll talk about what those movements mean in a little bit. So that is that rotation that can occur there as well. So this joint allows for rotation, like the pivot joint, but it also allows for multi-axial motion. And again, the hip and the shoulder are the only locations that you have them. They have the most flexibility of movement. And as we talked about, the shoulder has the most and is also most likely to be dislocated because the hip, being weight bearing, has some additional ligaments that attach it in place. So it has less flexibility of movement, but more structurally sound. So you're much less likely to dislocate your hip than you are to dislocate your shoulder.
So circumduction and rotation are type of multi-axial movement?
No. Circumduction requires either bi or multi-axial movement. Rotation does not require multi-axial. So if you think of the pivot, with the pivot, there's no change in the axis of that. You just have that rotation that is taking place. So rotation is non-axial. So pivot joints allow rotation. Axial joints allow change in angles, and a ball and socket allows both.
Okay.
Change in axes and a rotation.
Okay.
Okay?
Mm-hmm.
Excellent. And there you go. Just that simply, we have identified all 6 specific types of synovial joints. Now, as a couple people have pointed out, as your textbook has pointed out, all of these joints have names. And here's a table from your textbook, just so there's a small sample of the different joints that you are responsible for necessarily knowing, but you don't have to know the names of any specific joints. I'm not holding you responsible of the names of specific joints. You need to know what bone and bone features come together to form a joint, but you don't need to know the name of that joint. And I'm not going to pick some random joint out of the body and say, what specific type of joint is this? However, for every joint we have talked about, I've given you 1 or 2 examples, and you definitely need to know those examples. So you should know 1 or 2 examples of each of these particular joints that we've talked about. And again, all joints, not just synovial, but for all joints. But I'm not just going to randomly reach into a bag and pull out a joint and have you be able to know what it is. And you certainly don't need to know the names of any of the joints. Okay? Except for those sutures. There are those 4 sutures. Those are technically joints you need to know the name of. But I don't think there's any other joints you need to know the names of. All right. Questions on that? All right. So with that, we now know all the types of synovial joints, and we started talking about the types of movements they allow. But as we've also talked about, vocabulary is vitally important. So when we talk about the movements that our body allow, we need to know the correct terminology for these. So that, for instance, when we talk about the muscles in the next section, and I tell you that the trapezius muscle has 4 actions, where it abducts the shoulder, it elevates the shoulder, it rotates the shoulder, and it extends the head, you know what that means. So you need to know and understand the vocabulary associated with movements. And so when we come back from the break, we are going to go through the different types of movements, describe the different types of movements and where those movements occur throughout the body. All right, questions on that? All right, let's go ahead and take our first break then. We'll take a 15-minute break. So that means that we'll come back at 1:23. And at 1:23, we will restart the lecture and also do the recordings. And I'll start the recording at that point as well. All right. Questions on that? Yep, I can go back. Again, don't screenshot it. I don't want you to learn that information. No, not going back so you can screenshot it. I don't want you to know the names of those joints. You don't need to learn the names of the joints. All right? Excellent. Any other questions? All right, see you guys in 15 minutes. So are flat on the ground. So it is separate from the flex and extend that we have to do there. So we have that evert and invert. And the feet also get a special movement in that we can dorsiflex and plantar flex. Big will appreciate this because she just started driving, right? If you're late to school, what type of motion do you take with your foot to get there a little faster? There you go, exactly, like standing on your tippy toes, right? And what type of motion would that be?
Plantar flex?
Plantar flex, where you're flexing the plantar part of your foot to get on your tippy toes, right? Now, what happens when you see the police car? What do you do then?
Dorsiflex.
Do you plantar flex on the gas? I mean, on the brake?
No.
No, if you hit the brakes, they see the brake lights and you're getting pulled over. So what do you do instead? You dorsiflex the foot and hope for the best, right? So dorsiflex is when you standing up on the heels of your feet. Big here, when she was 2, continuously walked around the house on her heels for most of her second year of life. And so, yeah, that on the heels, walking around that way. So that is plantar flexion and dorsiflexion of the foot. All right. And then I think the last one, oh, excellent. Criminal tips, exactly. So the last thing we have to talk about, and this is, because we got the hand after this, so you're done if you want to be done. Okay. Or you can hang out if you want to. But
I have homework.
All right. Thank you for the help.
Yeah, have fun.
All right. So the last ones we need to talk about are supination and pronation. We have this joint here, and we know between the head of the radius and the radial notch of the ulna that give us this special relationship between the radius and the ulna proximally. And it gives us this interesting motion. There you go. Yeah, just do a Google search. It gives us this interesting motion to our bones. When we look at, for instance, when you look at my, come over here for this. When you look at my right arm in anatomical position, all 3 bones of my right arm are straight. And more importantly, my radius, that is way too big. My radius and my ulna are parallel to each other. So when I'm in anatomical position, my radius and my ulna are parallel to each other. However, I have this ability to be able to rotate my hand so that my hand projects posteriorly, my palm projects posteriorly. When I do that, of these 3 bones, the humerus, the radius, and the ulna, only one bone moves. That one bone that moves is the radius. So the humerus stays stable, the ulna stays stable, but what actually happens is that the radius basically rotates over the top of the ulna and it crosses. So basically the radius crosses over the ulna and the ulna doesn't move. So notice it's not a rotation. So we really can't use rotation when we're describing that. So instead, this movement of the forearm, we use the phrases pronation and supination. Supinate is what you would use to get into anatomical position. And pronate would be what you would use to project your hand posteriorly. So posterior for pronate is how I remember it. Your book's got one of those things. Yeah, exactly. I like dumb mnemonics to help to remember things, and absolutely. Your book uses the example, if your hand is supinated, you can hold a bowl of soup, whereas if it is pronated, you cannot. So that's supination to hold the soup. That's a good way to remember it as well. All right, and then of course, the last one is that opposition. And of course, opposition occurs where and only where?
Our fingers.
Well, more specifically, the thumb. All right, so the last place, the last special movement is that opposition. The thumb is the only opposable, that opposable thumb, thanks to that saddle joint, right, between the trapezium and the first metacarpal. All right. So that is our vocabulary. Not only do we need to know this for this exam, but as I mentioned, every single muscle you are going to learn in the next section. And how many named bones have we had to learn again?
206.
206, absolutely, excellent. Anybody know how many named muscles there are?
Probably like 800.
Oh, no, not that bad. It's only about 600. Only a little over 600 named muscles. So there you go. So that's not so that bad. Don't worry, you don't have to learn them all. Only about 520. So it's really not that bad. No, I'm just kidding. No, you're not going to even need to know anywhere near that. But for all the muscles you will be responsible for, you are going to need to know the actions, and you need to use the right terms. So you can't just say lift your arm or something like that. You have to say flex. And that's the last thing that I would say. When you talk about a joint, and let me write this out to make sure we emphasize it. When we talk about a joint, the movement of a joint, you can either identify the joint itself or the part of the body that moves. So, for instance, if I were to describe this action, right, this action right here, I could either say that it is a flex of the elbow, right, that describes the joint where it took place, or I could say it is the flex of the forearm, right? One describes the part of the body that moves, one describes the joint where it takes place, right? I can abduct my shoulder, or I can abduct my arm. Both ways are fine ways of describing it. So you can identify the part of the body that moves or the joint where the movement takes place. All right. Questions on that? All right, that is everything that we are responsible for. Oh, actually I lied. Excellent. Okay, so one more part that we need to do. And for this, it is already starting to get cold out here. I want to talk about homeostatic imbalance of our joints. So when we talk about the homeostatic imbalances of our joints, obviously one of the main effects is aging, right? Aging effects include a decrease in synovial fluid production, right? Like I said, Little didn't want to come out, but Big came out here to do these exercises for us and show us all those motions. And she was able to pretty much get off the couch and come out here and do that, right? Or if she wants to go running, she gets off the couch and goes running 5 miles without any problem at all. I want to run 5 miles. Can I just jump off of the couch and go do that? No, I need to stretch for hours pretty much beforehand. And one of the reasons for that is as we age, the synovial fluid that is produced in our joints decreases. So it's one of the reasons why stretching is so important, not just to maintain the flexibility and the limberness of the joints, but the movement of the joint increases synovial fluid production. And so the more synovial fluid you have in there, the more protection that you have for that cartilage, the less impact you're going to have. That decrease in synovial fluid means that there's less lubrication. You're much more likely to be, and again, the years and years and years of rubbing those joints, especially weight-bearing joints, you're going to get a thinning of the articular cartilage. And not only can it thin, but its surface can become irregular with pockets or tears in it as well, which makes the movement more rough for that when it occurs. Right? Again, as we just finished talking about, you lose length and flexibility to your ligaments. Your ligaments shorten and they tighten, so you have less flexibility. So we could all do those back bends when we were older, but as a 60-year-old, you know, you're not able to necessarily do those types of things anymore. And one of the keys is that there are big differences between what people are able to withstand in their joints. And one of the strongest components of determining that are your genes, right? Professional sports are one of the greatest places you see this. You see baseball players who play catcher in the major leagues for 14 years. Or something crazy like that. And that doesn't include the 2 years they played in college and the 4 years they played in the minors and the 6 years they played catcher as a little leaguer and things along those lines. That bending down and being in that squatted position puts a tremendous amount of wear and tear on the joints. And many people, even after just a year of trying to play catcher, have to stop because of the damage. But genetically, some people are better at it than others. Right? Weightlifting, running, there's a lots of huge influence on how much impact we can do on our joints, and our genetics are one of the primary ways that do that. So if your parents have good joints, you're likely to have good joints. If your grandparents don't have good joints, you're likely to not have good joints. There's a huge genetic component to it. Now, of course, what do we call the condition where you get that damage and or inflammation to the joints?
Arthritis.
Arthritis, absolutely. However, arthritis means a lot of different things. There are over a dozen different types of arthritis. And while arthritis is an inflammation of the joints, they can be caused by and affect very different things. And I think the place we see this the best is if we look at the two most common types of arthritis. Let's look at the two most common types of arthritis. The first most common type of arthritis is what we call osteoarthritis. Osteoarthritis is commonly what we refer to of the wear and tear of a joint. So with osteoarthritis, which type of joints are typically affected by osteoarthritis first?
Axial.
The hands.
Okay, I like where you guys are going with this. So you got the right idea. So the hand is a good example. What would be another example?
Knee.
There you go, exactly. Osteoarthritis typically affects either weight bearing, so big weight bearing, or heavily used joints. Notice where the hand or the wrist was an example someone used. That's not a big weight-bearing joint, but if you're a cashier, if you are a sewer or something along those lines, pianist, right? These are ones that are when heavily used, hairdresser, these are ones that get heavily used, and that heavy use can cause the wear and tear. Absolutely. Now, again, even if you're that catcher squatting down, are you equally likely to get damage the same on the left and the right? Or that hairdresser
No.
or things along those lines? So this is typically asymmetrical. Now, again, that doesn't mean that it can't affect both sides, but it typically doesn't affect both sides equally and typically not at the same time. Right, so big, large, weight-bearing, typically asymmetrical in its use. And I know this is going to sound silly, but this just affects the joints. All right, typically damage to the cartilage and to the bone in that joint. So if you're like my grandfather, Yeah, Baker's probably another great example. Absolutely. My grandfather had osteoarthritis in both of his knees and had both of his knees replaced. And the thing that my grandfather loved to do more than anything else was to play tennis. So after his both of his knees were replaced, he would walk out to the tennis court with his walker, put his walker down, get his racket, step out onto the court, kick your ass at tennis, and then go back and take his walker and go back into the house. Once he got those knees replaced, did he have any more problems with the osteoarthritis? No, it was completely gone and he was completely fine. And the walker he just kept around to make you feel bad. Right. So again, once that joint is fixed, then the problem is resolved. Right. So it's typically asymmetrical, just affects the joints. And with osteoarthritis, is it better in the morning or better in the evening? Is it better? Yeah, this is typically better in the morning. Oops. You wake up in the morning and you haven't been using that knee for the past 8 hours, right? Then as you get up and move around, the more you move around, the more pain. So this one typically gets worse with use. Right? Let's compare this to our second most common type of arthritis, and that is rheumatoid arthritis. Is rheumatoid arthritis caused by wear and tear?
No, I think it's an overproduction.
Say again?
Of synovial fluid. Overproduction of synovial fluid, I'm guessing.
It's not necessarily an overproduction. There you go. That's what I was looking for, Amanda. It's actually an autoimmune disorder. Right? With an autoimmune disorder, what this means is that the body's own defense cells, our body's protective cells, our white blood cells, actually attack our own synovial membrane. Destroying the synovial membrane, producing scar tissue as a result of that. So let's think about this. In that big knee, in that big hip, if my white blood cells destroyed a square centimeter of synovial membrane, would that really change the function of my knee?
Tiny bit.
Tiny
Maybe.
bit. But what about if I lost a square centimeter of synovial membrane at this joint right here between my distal and my middle phalanges? Would losing a centimeter of synovial membrane there make a big difference?
Yes.
Yeah, so notice in this one, typically it affects the smaller joints first. Now, again, that doesn't mean that you can't get rheumatoid arthritis in your knee or in your hip, but it typically starts in the smaller joints first. And because these are white blood cells that are in your body and can go everywhere, if they're going to affect your right hand, are they also going to affect your left hand? Yeah, there you go, Daniel, exactly. This one is typically symmetrical, where it's going to affect both sides evenly. Now, again, it doesn't mean it's going to be perfectly even. Remember, we keep talking about this being typical, but it is most likely going to have effects on both sides of your body. And notice, because this is an autoimmune disorder, this doesn't just affect the joints. If I have rheumatoid arthritis here and I replace this joint, which isn't something they can do, but let's just say for argument's sake that it could be done, would all my problems go away? No, because I would still have those cells in my body that would attack other joints. And not only can it affect other joints, but it also can affect other organ systems. It can affect the skin, it can affect the lungs, it can even affect the heart. So this is a disorder that doesn't just affect the joints, but it affects other organ systems as well. And grandma, how does she feel first thing in the morning when she wakes up? Well, okay, that's actually a great point. Both of these do have a bit of a genetic predisposition, right? Again, your joints could be predisposed to more wear and tear. Your body could be predisposed to rheumatoid arthritis. It's not fully genetic. So just because grandma has rheumatoid arthritis doesn't mean you'll have rheumatoid arthritis, but it does mean you have an increased likelihood. But the same thing is true for osteoarthritis, right? If they have it, then there's as well. So again, yeah, I like that, about 15 to 25%. There is an increase influence of it, but it is dramatic. It's not, there is a genetic component, but it appears to be more of a predisposition as opposed to you actually getting it, guaranteed from those genes. All right, and so what about grandma with her rheumatoid arthritis? Is she better first thing in the morning when she hasn't been moving that hand for 8 hours? Or is she better after she's made her cup of coffee and moved her hands a little bit and she's holding her cup of coffee where she's holding onto that mug and the warmth is radiating into her fingers, right? And the warmth and the movement increase the synovial fluid production and those hands get better. So this one is typically worse in the morning and gets better with use. Now, if she uses it too much, is it going to be fatigued and is it going to be tired? Is it going to be sore and it's going to bother her? Yes. But when she can get some warmth into it, when she can get some movement into it, that's going to increase the amount of synovial fluid. Because remember, this one's affecting the synovial membrane. And so when we can get a little synovial fluid in there, it'll get a little bit better as a result. All right. So there you go. Both of these are arthritises. But as you can see, they're very, very different in how and what they affect in the body. And so remember, arthritis just means inflammation of the joint. And there are lots of things that can cause it, but these are the two most types. So yes, there is a specific type of rheumatoid arthritis called juvenile rheumatoid arthritis that can, for some individuals, be grown out of. Rheumatoid arthritis can also sometimes be brought on by pregnancy. And when the pregnancy ends, those symptoms can sometimes go away. Those are more rare types of them, but yeah, so even, excuse me, with these, there are different types of them as well. We could spend a whole class talking about rheumatoid arthritis, and we'll talk about it more when we get to 431 and our immune response and what goes wrong with that as well. All right, excellent, great questions. So that is now everything we need to talk about joints. Questions on any of that? All right, so here is what we are going to do. It is 2 o'clock now, so I'm going to break you guys into your groups. We will take our break, and then we come back from our break. I will do my introduction to the bones of the lower appendage, and then we will finish off the rest of our group presentations. And we're doing good on time, so we should still hopefully have at least a half an hour, if not more, for some question and answer review questions. All right, any questions on any of that? All right, excellent. Let's take a 20-minute break because that'll give me time to get you guys broken up into your groups and for you guys to coordinate and then also take your break. So we will come back at 2:20. So at 2:20, we will start up with our group presentations. All right, I will see you guys in 20 minutes. So let's stop sharing that.